Is this thick or thin? Definitely thick because we got this stratum lucidum right there. All right. We can clearly see the epidermis. We can see dermal pegs and the epidermal ridges, which provide that interdigitating thing where we've got hemidesmosomes keeping things together. Right in this region is the interface between the upper dermis and the lower hypodermis. And note that we've got lots of secretory units of what down in the hypodermis? Sweat glands, and more particularly eccrine sweat glands. All right. We can see a bit of a duct coming up, which we know will empty here. Now, the dermis has two layers, a papillary layer and a reticular layer. The papillary layer supports the epidermis itself. And if I were going to trace the interface between papillary and reticular layers, it would be somewhat like this. You can see that down here in the reticular layer, look how thick those collagen fibers are. Big and thick. There are collagen fibers up here, but they're not so thick. So papillary layer, reticular layer. Remember, the reticular layer is what kind of connective tissue? Dense irregular. The papillary layer, I mean, we could call it a loose connective tissue. It's not quite as loose as the lamina propria of the intestine, but it's still pretty loose. All right. So when I'm looking at epidermis, the first thing I zero in on is the stratum granulosum. So we see that right here. We've got a little bit of lucidum above it. And then the thing to think about is the layer of the epidermis that is in contact with the papillary layer of the dermis is the stratum basale, or the basal layer, or the germinativum. So any one of these cells right here, single cell layer coming all the way down, is stratum basale. Then between that has to be the spinosum, lucidum, corneum. It just occurred to me, actually, Nigel asked me, why does the lucidum not stain and the corneum does pick up stain? Possibly, the granulosum, in addition to the keratohyalin granules, has a membrane coating granule, which is a lipid substance that it puts out and it forms part of the waterproofing barrier of the skin. That may prevent, at least in the lucidum, it picking up stain. But as cells get pushed out of the lucidum, they start to fall apart. That may explain why the corneum picks up more stain, as we're seeing right here. Total speculation. But. All right, thin skin. Again, we can focus, here we've got just one single layer of granulosum. Everything above it is corneum. A couple layers of spinosum, and then we've got our basal layer. So basically the epidermis is thin. So when we talk about thick and thin skin, we should really be talking about thick and thin epidermis, okay? This is quite nice because it's slightly higher power, but you can see clearly the difference in the collagen fibers in the reticular layer relative to those up in the papillary layer. So this is roughly the interface between papillary dermis and reticular dermis. Thin skin again. But this is from someone that has darker skin, and you can start to pick up then the melanin, which you can see is clearly in these basal cell layers, and it's starting to get up into the spinous, upper spinous layers of the stratum spinosum. This is a cool shot. Nigel was talking to you about desmosomes helping to keep the spinosum together. So we've got two keratinocytes, one here, one here. I'm going to trace the intercellular border. So you can see it's the actual plasmalemma of these cells interdigitate, providing lots of room, surface area for those spot wells that keeps everything together. I put this in sideways. and I don't really like to show you cartoons in this thing, but it does show nicely a melanocyte that's insinuated itself into the basal lamina and sticking right under the basal layer. You can see that it does these little processes, which is nitromesh, are basically phagocytized by the keratinocytes so they can get the melanocyte. Now, this is the coolest prep ever. You know that the dermal epidermal interface has hemidesmosomes, and there's a lot of collagen fibers at reticular layer. If you take skin and treat it with collagenase, so you digest away the collagen, you can actually lift the epidermis away from the underlying connective tissue. You lift it away and lay it like this on a slide so that the bottom layer, the stratum basale, is pointing up, and then stain for melanocytes. You can see how these puppies populate the epidermis. And again, depending on where you are, underarms, it's 1 in 10, 1 melanocyte for every 10 keratinocytes. Where you see more sun, it's 1 in 4. All right? So a lot of the slides of follicles that I looked at today didn't show that connection with the overlying epidermis. You can see this quite nicely where this thin skin kind of invaginates, forming the follicle. Right? So clearly explains why we're talking about an epidermal appendage. The other nice thing here is you can see the associated, what are these? And what's really cool is you can see the actual continuity of the duct into the follicle itself, here and here. So these guys empty into the follicle, and you can start to pick up the hair shaft right there. All right, so we're at what interface here? What's here? And reticular layer of the dermis. You can see that we've got a beautiful secretory unit of an eccrine sweat gland, and these darker structures then would represent the what? Where is the sweat? How does the sweat get onto our surface?
Ducts.
Duct. All right, so you can see it moving in and out of the plane of section. And again, keep in mind that this is way down in the dermis, in the upper levels of the hypodermis. I think that's what I've got for skin. Nigel threw a curveball at me and did skin first, so I did it the other way around. What are we looking at here? Major conducting passageway. You can feel the rings of it right here in your throat, trachea. Remember, we were talking about something that's about 2.5 centimeters in diameter, maybe 10 centimeters long, and 20 of these C-shaped rings, which again, you know, you can palpate on yourself. This is the back side of it. So again, we've got the cartilage, hyaline cartilage. This is all fold artifact, right? These lines right here. We've got the submucosa and the mucosa. On the back side, we've got a break in the section, but right in here we've got smooth muscle, which we call the trachealis. And that's important to increase the velocity of air moving out of your lungs if you're coughing. You decrease that diameter, you can get the force up to 100 miles per hour. Help dislodge whatever may be stuck in your throat with a cough. You can also pick out at low power, this low power shot, I think I burned the battery up here. The seromucous glands right in here. So in addition to the goblet cells, we've got an extra component, as Nigel mentioned in his lecture, the seromucous glands. And that's all going to form that mucus layer, which is hydrated in, you know, the ciliary, mucociliary elevator, thank you, sir, that helps trap particulate matter, and you either swallow it or spit it out. Nice shot here. Looking at some of the epithelium for goblet cells, they were a little hard to come by, but here we can see them nicely. Oh, wow. Here's a goblet. Notice the cilia here, and you see that dark line right underneath? Those are the basal bodies, which originate, if you will, the microtubular structures in the cilia. And notice right here, you've got a break in that line. That's a clue for looking for a goblet cell, because goblet cells obviously don't have cilia. Nice thick, where'd you get this? I kind of like the color. Nice thick basement membrane. And then we've got lumina of seromucous glands, okay? Underneath, we've got your hyaline cartilage. Again, I don't usually show you diagrams here, but as you have the time to look at the lung slides in this lab, you don't have something that's nice and clean and clear cut, all right? So let's start from what's clean and clear cut. We've got a terminal bronchiole, no breaks in the wall. You get into the respiratory bronchiole and you have these smooth muscle knobs and an occasional alveolus outpocketing on the wall itself. And then it breaks down into the duct, the sac, and individual alveoli. Here's a diagram showing a blood vessel right here. Any blood vessel you see associated with the bronchiolar tree or the bronchial tree, you can almost assume is a pulmonary artery or a branch thereof. Okay? Coming up, I'll show you a way to distinguish that, and Nigel already did in terms of presence or absence of internal and external elastic lamina. All right, let's look at the kinds of reality that you're likely to see in your slide set. Again, here we can see that folded or scalloped luminal profile, and that's happening because of that smooth muscle that Nigel talked about. When it's exposed to fixity, it causes it to contract, which throws the lumen into those folds. So you've got some sort of bronchiole here, big blood vessel associated with a bronchiole, so we're going to say pulmonary artery or branch thereof. Come down in here, well, first you can see a bunch of alveolar or dust cells chewing up pigment, so macrophages. But here, we've got thrown into folds, so likely to be a terminal bronchiole, all right? As we follow it out, not as nice as the diagram I showed you, but clearly you're getting some outpocketing. So I would posit that we're looking at the transition from terminal bronchiole to respiratory bronchiole right there. Higher power, see that folds, epithelium really thinning out here, really thin in here. This is, gas exchange is happening right in here. Not so much here, maybe right there. That nice micrograph that Nigel just showed you. So you've got, what, low columnar, high cuboidal. Again, transition that's ciliated here. Here you can see those basal bodies. We've got a chlorocell that sticks up, and it produces a surface active protein that actually prevents the walls of the smaller bronchioles, the terminal and respiratory, from adhering on expiration. So it's kind of acting like a surfactant, but not quite. And we've got smooth muscle down here. This is really cool. Let's look at the upper panel of the scanning electron micrograph. So here they've labeled terminal bronchiole right here. If you look down here at part B, you might be able to hallucinate some of these alveolar outpocketings relative to here where you're seeing lots of chlorocells poking their heads up, all right? Down here, when you get into an individual alveolus, you can see how thin the wall is. We'll come up to that. But notice, if you look here, you see all sorts of little openings. These are called alveolar pores, which allow for some confluence between adjacent alveoli. So there is a connection there, which happens to be quite nice if you've got something like emphysema. Allows you to still get along in spite of the fact that your lungs are falling apart. Nice low power transmission electron micrograph. So this space would be alveolar space, alveolar space, alveolar space. You can see red blood cells here in the capillary. And right where the arrow is, that's the blood-air interface. That's that interface that Nigel showed you, that beautiful micrograph. And you're talking about maybe a half to maybe a micron thick. And so just hold on to that. You can see that there are other cells here that clearly aren't these thin type 1 pneumocytes. So you can have type 2 pneumocytes. You could have macrophages that are either within the septum here or in alveolar space. So here we've got an expanded view of what Nigel showed you in his lecture. Erythrocytes, so here's your capillary. Asterisk is in the cytoplasm of a type 1 pneumocyte. There's a basal lamina here, and right in here is the cytoplasm of the endothelial cell that forms the wall of the capillary. So clearly, 7 to 8 microns, I mean, you're talking a half micron, so you want to reduce the distance for diffusion, all right? If you think about geometric shapes, excluding the shape of a red blood cell, all right, the sphere has the most surface area to volume ratio. And what we're trying to maximize here is surface area for diffusion, all right? One of the problems that comes along with that is that you've got greater surface tension forces that are trying to collapse that sphere, which is why you need a phospholipid like a surfactant to reduce that surface tension. And that's the job of this type 2 pneumocyte shown here, and all these secretory granules here, which when they open up, that lipid kind of unfolds like an accordion and provides that surfactant layer to reduce surface tension. Note that you've got tight junctions here and here, which join a type 1 pneumocyte to this type 2 pneumocyte right there. Again, you've already seen this one, but now with your a little bit of knowledge, you can identify the type 1 pneumocytes, aside from the fact that they're labeled 1, smooth surface cells, all right? The type 2 pneumocytes have little stubby microvilli. They're the ones that are spitting out those secretory granules sitting here. And of course, you've got this dust cell or alveolar phagocyte sitting there. Okay, pulmonary arteries. If you stain with an elastic stain, you're going to pick up an internal and external elastic lamina. As Nigel mentioned, the wall is going to be thin because the pressure it's seeing is low. I think what we're talking 25 millimeters of mercury coming off of the right ventricle. That's in contrast to 120 or so coming off the left ventricle. So, pulmonary artery, internal and external elastic lamina. Got your capillary circulation and pulmonary vein. No internal elastic lamina, but it has an external, all right? Again, thin wall, and these red blood cells in here are loaded up with oxygen, okay? It's not deoxygenated. And then here's your bronchial vessel, which tends to follow the bronchial tree also as you're going in. And it's got a nice internal elastic lamina, big thick wall because it's seeing pressure is 120 millimeters of mercury or so. Don't forget that you've got a lymphatics, and here you can see a valve right here. That looks like it might be what? Part of the wall of what? Some sort of bronchial, right, exactly. So that tells you I don't have an elastic stain here, but that this vessel right here is probably a branch of a pulmonary artery, all right? And that's all she wrote. That was your quick and dirty version here.